This presentation came about with Amaze and the Parent Carer Forums surveying parents across East Sussex, Brighton and Hove and West Sussex for their questions about FASD. And we also asked for feedback on current services for the NHS Sussex. We have tried to answer as many questions as possible within this presentation, and we have shared your anonymised feedback with NHS Sussex Commissioners as promised. So this presentation, there'll be some introductions from myself and from Dr. Bond. Dr. Bond is going to do an overview of FASD and of the diagnostic process and criteria. I'm going to speak a little bit about support strategies, services, and support in the various areas that we'll cover. So who are we? I'm going to let Dr. Bond introduce herself now.
So yes, hello, my name is Michelle Bond and I'm a consultant community paediatrician based at Seaside View Child Development Centre in Brighton.
And I'm Serene Russell. I'm a parent of 4 children aged between 12 and 29 and a parent carer of our 12-year-old who was diagnosed with FASD approximately 3.5 years ago. So I'm going to hand over to Dr. Bond to go over the overview of what is FASD.
Thank you. So what is FASD? So FASD stands for Fetal Alcohol Spectrum Disorder, and this is a term describing a range of developmental difficulties related to prenatal alcohol exposure. It's a lifelong disorder, and difficulties often become more apparent over childhood and adolescence. Children may or may not have some characteristic facial features, which I'll cover later on in this presentation. And children and people with FASD can present with a range of difficulties that may overlap with symptoms of other neurodevelopmental disorders. There is not a characteristic profile as such like there is in autism or ADHD. However, there are some symptoms which many people with FASD do have. So every child and person with FASD is different, but they may have difficulties with understanding social rules. They may seem superficially bright and chatty, but have difficulties following complex instructions and abstract language. They may have difficulties with attention and concentration, and may have difficulties with planning and organisation. And the performance may seem to fluctuate from one day to the next day. So a person with FASD may seem to be able to do something one day and then may not be able to do it the next day, which can be confusing for people working with that child or young person. So, as I said before, the symptoms of FASD may overlap with other neurodevelopmental conditions such as ADHD and autism. And in fact, people with FASD may also meet diagnostic criteria for ADHD or autism, for example. And also, some of the characteristics may overlap with symptoms of things like developmental trauma. So some of the things I've got down on this slide include people may be easily distracted, they may interrupt, they may have difficulties with transitions, they may have difficulties with eye contact, and they may have difficulties with their speech patterns. So as you can see from this slide, there are overlapping characteristics, and if people with FASD also meet criteria for autism or ADHD, they may also have that diagnosis as well as the diagnosis of FASD. It doesn't have to be and, or it can be both things. So people with FASD have an uneven profile. They may have strength in some areas and challenges in other areas. So this slide just gives an example of that. So this is a person with the actual age of 18. They have a strength in their expressive language, which is at the age of a 20-year-old, but contrasting with their comprehension and emotional maturity, which is at the age of a 7-year-old, and money and time concepts at the age of an 8-year-old. So this can lead to people overestimating or sometimes underestimating the abilities of a person with FASD. People with FASD often have difficulties with executive functioning. So executive functioning are your higher level skills which help you to organize, to plan, they involve your working memory, your ability to shift your focus, and your ability to initiate tasks. And people with FASD may have difficulties with some or all of these functionings. typically executive functioning increases significantly in typically developing young people at around the time of adolescence. So around the time they go into secondary school, typically developing children and young people have a spurt in their executive functioning abilities. However, people with FASD don't have that rapid increase over, typically don't have that rapid increase over the secondary school age. And as you can see from this graph, what can happen is that people with FASD the gap between executive functioning people with FASD compared to typically developing peers can widen. And this can lead to significant difficulties within secondary school, where you children then have to get themselves from class to class, remember which books to take to each classroom. So sometimes that transition into secondary school can be very, very challenging without the right support in place for people with FASD. So NICE, a couple of years ago, NICE developed some quality standards for FASD. And this is the first time we had any sort of national standards around FASD. So the NICE guidance quality standards say that people and children with probable prenatal alcohol exposure and significant physical, developmental or behavioural difficulties should be referred for an assessment. Quality standards also state that children and young people with confirmed prenatal alcohol exposure or the facial features associated with prenatal alcohol exposure should have a neurodevelopmental assessment where there are clinical concerns. So significant difficulties could be within a variety of different developmental domains, which can include learning, attention, memory, language, learning from consequences, difficulties with social skills, and difficulties with problem solving. They may also have some physical effects of antenatal alcohol exposures, for example, a smaller head circumference, and sometimes problems with other body systems such as heart or kidneys, vision or hearing. And again, they may or may not have the facial features associated with FASD, but significant difficulties indicate that the difficulties are disrupting the ability of the child, the young person or their family to function and carry out activities of daily living. So how do we make a diagnosis of FASD? Well, in the UK, we follow the SIGN guidance, which is the Scottish Intercollegiate Guideline Network. So they developed guidance in around 2019, and NICE decided to adapt the SIGN guidance, so we follow that in the UK. The SIGN guidance states that there should be evidence of antenatal alcohol exposure, and there should be evidence of significant central nervous system dysfunction with impairment in 3 or more domains. The child may or may not have characteristic facial features, and the difficulty should not be due to another cause. For example, shouldn't be due to a genetic syndrome. So just a couple of slides around alcohol exposure. So the current guidance is that there is no safe amount of alcohol to drink in pregnancy. Therefore, the advice is not to drink during pregnancy. However, the risk of harm is likely to be low if only small amounts of alcohol were consumed, for example, before the pregnancy was recognised. And the impact depends on things such as the pattern of drinking, the developmental stage of the fetus, individual susceptibility. So people, some women metabolize alcohol differently from other women, and that can lead to an increased susceptibility in the fetus. And there may be a possible increased effect if alcohol is taken with other drugs such as cocaine. So alcohol can affect the fetus throughout the pregnancy. So in the first trimester, this is where sort of body systems are developing. So you can have the characteristic facial features developing in the first trimester, and then sometimes there could be problems with things such as the heart, the kidneys, bones, and the eyes. If alcohol is consumed in the second trimester, there are increased rates of stillbirth and preterm labour. And in the third trimester, this is where the fetal brain is really developing rapidly. And alcohol consumed in the third trimester can have that impact on the learning, development, behaviour and emotion control. So just going back to sort of the diagnosis and looking into the guidance around alcohol exposure. So the SIGN guidance states that confirmation of prenatal alcohol exposure is needed for a diagnosis of FASD. Obviously, the best confirmation would be a direct report from the birth mother, or report from a reliable source who witnessed the birth mother drinking during the pregnancy. There could also have been reliable clinical observations. So this could be maybe a midwife who was caring for the pregnant woman during the labour and might have witnessed smelt alcohol, for example, or witnessed signs that the woman was drinking during the pregnancy. There might be medical records which document positive blood alcohol concentrations during the pregnancy, or there may have been alcohol treatment during the pregnancy, or other issues related to alcohol use during pregnancy. So, for example, being stopped for drunk driving during the pregnancy. But the sign guidance states that unsubstantiated information, so somebody thinking that the birth mother probably would have been drinking, is not enough information, is not enough confirmation for a diagnosis of FASD. And we can't use lifestyle alone. Use of other drugs or alcohol exposure in previous pregnancies in isolation to confirm alcohol consumption during this pregnancy. So moving on to the facial features in FASD. So as I previously mentioned, you do not have to have the facial features of FASD for the diagnosis of FASD. And only about 10% of people with FASD have the facial features. However, these will be assessed as part of an FASD assessment. There are 3 characteristic facial features that can be seen in FASD. These are the smooth philtrum, which is the groove between the nose and the top lip, a thin top lip, and small eye openings. These are the 3 facial features that are used in the diagnostic assessment. However, there may be other facial features associated with FASD, such as a low nasal bridge, a flat mid-face, and undeveloped jaw. These features are not specific for FASD, and therefore they're not used as part of the diagnostic workup. So moving on to the neurodevelopmental assessment. So this is an assessment by a multidisciplinary team which covers a range of different developmental domains, including motor skills, neuroanatomy, cognition, language, academic achievement, memory, attention, executive functioning, affect regulation, and adaptive functioning and social skills. So not all of these domains need to be assessed in detail. However, if there is a concern that the child or young person has significant difficulties in one or more of these domains, then they should be assessed. And within the diagnostic criteria, for a diagnosis of FASD, you should have a significant impairment in 3 or more of these domains. And usually the criteria for significant impairment is functioning below the 2nd centile. So if we take, for example, motor skills, if you have 100 children of the same age and you're assessing their motor skills, 2nd centile would be the bottom 2 of that 100 children for that domain. When we're thinking about FASD, we also have to think about any other important factors that might be contributing to the child's difficulties. So we have to ask about things such as other substance misuse in pregnancy, any other conditions such as genetic conditions, neonatal problems such as prematurity, postnatal abuse and neglect, and other family histories of learning difficulties. So once the prenatal alcohol exposure has been assessed, the facial features have been assessed, and the central nervous system assessment has taken place, we look at the diagnostic algorithm to decide whether the child meets the criteria for a diagnosis of FASD or not. So just looking at this, this is the diagnostic algorithm from the sign guidance. So if we look at this, when there is a confirmed prenatal alcohol exposure, and the child doesn't have the facial features, but meets the CNS criteria, they would get a diagnosis of FASD without the facial features. Where the alcohol exposure is unknown, if the child doesn't have the 3 facial features, then an FASD diagnosis can't be made according to the sign guidance. But where alcohol exposure is unknown, but the child does have the 3 sentinel facial features and they meet the CNS criteria, they may have a diagnosis of FASD. So that's where the facial features, I guess, where it's really important for the assessment of the facial features where you don't have the confirmed alcohol history. For very young children, where there is confirmed alcohol exposure, they may or may not have facial features, but they may be too young for a comprehensive CNS assessment. If there are concerns about their development, however, we'd put them in the at-risk category, which means that they're at risk of developing FASD and further assessment may be needed later on.
If you are seeking an assessment for FASD, where can you go for this information? The NHS website has a section on what to do if you think your child has fetal alcohol spectrum disorder, or FASD. The National Organisation for FASD also has information on getting a diagnosis. FASD cases can be referred to the NHS National Clinic for FASD at Redhill by local health providers. You can ask for this and it will be considered, but be aware that it may not be agreed in all cases, and there's a link. For Brighton and Hove carers, Michelle has recorded details of the local assessment pathway. You can find this information right at the end of the recording. We understand that pathways in Sussex are changing and developing. We hope there will be more information to share about this in the future, and we will make this available when we can. So I'm just going to do a light touch on some of these strategies, because as you'll see, a few of the ones that I'm going to talk about, they could take a whole day of learning in themselves. I hope this will just give you a bit of a taste of where you can maybe go and get some more information and research the areas. More and more information is emerging as parent carers and professionals are coming together and working together and looking at strategies that can be used to support our children and young people with FASD. Bearing in mind, each family unit and each child, as Michelle has already alluded to, is different. And so a lot of this will be trial and error to see what actually works for you, your family, and for your child or young person. So I'd recently done a course with Salford University, and this is one of the slides they shared with us, which I thought was just really important for both myself as a parent carer, for our family, our friends, and also for our teachers. It's the 8 magic keys, and you'll see that the one in the center says the master key. And the master key is about developing trusting relationships for our children and young people. And this is all important for them in so many different aspects of their life. Some of the keys that we talk about is around concrete. So this is about talking in concrete terms, not using abstract language with dual meaning. And really, if we think about where we communicate with our child, young person, if we can think younger, because if you can relate to a younger child, the likelihood is that the older child is going to be able to understand what we're saying to them. Second one is consistency. So again, using the same words and strategies, and this is where it's really important for us to be communicating with all the professionals that's involved in our child's care and our family and our friends, that we're all using the same things. The children with FASD struggle to generalize learning in one area and then transfer that learning to other areas. So if we can keep things as consistent as possible, it's going to actually help them immensely. Then repetition. As Michelle has already spoken about, our children will often have problems with working and short-term memory. And so the need for repetition is so important. Do it again and again and again. And just when you think you've got it, you might have to redo it again. I like the one where it's got KISS. Keep it short and sweet. So simplicity. Our children are very easily overstimulated, and once you reach that point, they're going to shut down and no further information is going to get through to them. So if you can keep it as short and sweet as possible, the likelihood is they can actually understand it, they can actually remember it, and then they can actually do the task. Supervision. So this is where we're going to scaffold independence, and this can be quite tricky when we're starting to look at the ages of 12, 13, 14, 15 and older, where a lot of their peers and their friends are starting to do things independently, and they want to do the same thing. And this is where we really need to navigate how can we actually help them to become independent, but in a safe way, and build appropriate habit patterns. Structure. So this is the glue that makes the world make sense for them. And without structure in their life, other things can actually fall down. Be specific. So say exactly what you mean. Give examples. Use visual aids if you need to, but be explicit. Don't think that actually, well, they know what I mean, because often they actually won't know what you mean. And then routine. And this is really, really important because our children will have difficulty in predicting what may or may not occur and then adapting to change at pace. So if we can have routine in place, this will help reduce anxiety and then will help them learn and be able to continue with tasks. So emotional regulation, and this is just such a huge area of our children's and our lives. So as I say, I'm just going to touch on this. So signs of emotional dysregulation, you'll see they'll have overly intense emotions, they'll have impulsive behavior, not thinking about what might be a problem or might be a risk. They'll have a lack of emotional awareness, trouble making decisions in even the smallest areas of their life, inability to manage those emotions and behaviors, and often avoiding difficult emotions and avoiding conversations or avoiding places or avoiding people. And what we'll notice with our children that they'll demonstrate the fight, flight, or freeze response. And often the freeze response can actually be overlooked a lot, especially during school time, where the child does that minimum amount of work that doesn't sort of bring them to the attention of any teacher or anything, but actually they're in their freeze mode. And during that mode, actually, they cannot learn, they cannot function. But often it gets overlooked. And so it's really important for us to be able to advocate on our child's behalf in any of the environments that they find themselves. However, once they have become dysregulated, it's very difficult to reason with them. And we often talk about when their lid has flipped. You cannot reason with children at that point. It's really important for you to learn to just wait until they've been able to get into that calm zone. And then at that point, if you want to see if you can try and discuss the episode or what's happened and how they're feeling. One of the models that was introduced in one of the courses I done was the STAR model. And this is really important for us to have diaries or to look at what's happened to our child, why it's happened, and then if we can advocate for them to other professionals. So the STAR model is looking at the setting. So what was the environment at the time? What was the temperature? What was the child doing? Who was with them? Just what was happening around them? The trigger, were they asked to do something? Were they asked to stop doing something? Was something taken away from them? Did somebody walk in? Was there noise? What happened? What was that trigger? What was the action? What did we observe the child then doing, saying, behavior, anything at all that you observed? And then what was the response of people around them? What helped? What didn't help? And by doing this again and again and again and having a diary, we build a picture of things that actually can help our child or help the people around our child to help them. The important thing for us to try and do is to help regulate. And this is for us to be able to regulate our emotions as well as for the child themselves. And regulating can be done through various ways. And as I said, each child is different, each family is different. But some of the ways that we can do some regulating is through play and positivity. Playing is just such an important thing because it elicits that feeling of joy, that feeling of bonding, which some of our children may not have had in their early years. And positivity. And sometimes it's really hard when we're having a really tough time to find those positive things to say or to bring out, but it's really important that we try and do that. Regulating through diet and sleep, and I know that this can be quite a difficult area as well for a lot of our children around eating and around sleeping, but that's really important. If we can try and find ways to help them, this is an area that we can try and help with regulation. Being proactive and preemptive, and so when the children are a bit younger, this is our responsibility really. What can we be proactive about? Finding out for our children, learning for our children, and then advocating for our children. Preempting things that we know are going to be difficult for them. And then this is something that we can try to start teaching them so they can self-advocate as they get a bit older. Simplifying, slowing down, and consistency. Again, in this day and age, it's really difficult to do the slowing down. but often our children need that time to process in order for them not to get dysregulated. Regulating through empathy and acceptance. So showing our children that we're accepting them for who they are and not about all the other areas that they're having difficulties with. Coming alongside them and showing them some empathy really goes a long way to actually helping them. And regulating, and this is possibly the most difficult one, but that you're going to be hearing a lot about for parent carers, is self-care. So if we're not looking after ourselves, we can't possibly look after everybody else around us. So that might just mean 5 minutes here or 5 minutes there. It might mean an hour here, an hour there, but it's really, really important to look after ourselves so we can look after everybody else. I'm not going to go through everything on here, but you could perhaps pause the video at this point and just have a look at communication. Communication is so important because when there's a miscommunication, things are going to unravel. So just let you have a bit of time to look at the strategies on the left-hand side and what to do about those strategies on the right. So confabulation, this is a term I had never really heard of until the diagnosis came along. And it's a term used for when individuals with FASD fill in the blanks of their stories. The storytelling may be the result of trouble with working and short-term memory, as Michelle has mentioned, issues with thinking in a logical way, or struggles distinguishing between reality from fantasy. And confabulation may be misunderstood as lying, but often this exaggeration, it can make sense and becomes true in the moment for those that are actually telling the story. So some of the things to consider is ask short questions with definite answers. So when my daughter's trying to tell us something and I can see she's really struggling with her memory here, we might often use yes or no answers for some of the questions that we'll use. Ask them maybe to tell you what happened, but in a different way. Ask them maybe to write it down or to draw it or to use small world play figures to try to explain what happened. Remaining respectful and understanding at all times. And sometimes it's really a lesson in patience, because you've got to be very patient as they're trying to tell you, or you're trying to unravel what really happened. And understanding that lying has an intent behind it, but confabulation doesn't. This is one area I think that we really need to advocate for our children, especially in education, because this is where it can be misconstrued mostly by not just their teachers, but also their peers as well. So sensory processing, this is just such a huge area all on itself. So again, we're just doing light touch here. But when we think of our senses, we typically think of our 5 senses of sight, hearing, touch, smell, and taste. But actually, there's 3 other senses that are really, really important within our children with FASD, and those being interoceptive. And that's the awareness of our internal organs. So for instance, the awareness of we're feeling full now, or the awareness of, well, my bladder's full, so I need to go to the toilet. And you can see already where there's problems with interoceptive senses, that there could be problems for our children, such as toileting or such as appetite, having a very little appetite or having an appetite that's never ends. The vestibular sense, where you've got that sense of balance and motion. And again, where there's an issue there, sometimes that can affect our child's ability of, navigating environments without bumping into things or falling. Or and so again, it's helping our child or the carers or professionals to understand that. And the proprioceptive senses, so the sense and awareness of your body's position. So for instance, if I have my hand up here, there's lots of information that's going from the joints and tendons, etc., to my brain to say, your hand is up here. Now there's a problem where this can sometimes be a problem for children with FASD. And you might find that they put a glass down very heavily, or they give you the biggest, strongest hug, but actually for them, they don't realize that they're giving you a really, really tight hug, or they've put that glass down very heavily. All of these senses work to help our bodies feel just right. They filter out unnecessary information. They use the necessary information for us to get to that just right feeling. But this is reliant on simultaneous function of many areas of our brain. Now, FASD can often feel sensory hypersensitivity too much, hyposensitivity, too little, and this leads to some sensory seeking as well. Now, you might find some of your children will have sensory circuits at school. So this is part of the alerting, the responding, and then the calming senses. This helps to hopefully explain to friends and family and teachers why maybe the child is having a problem with some areas. So the impact of having a problem with their senses can lead to them not able to interact with the rest of their environment. It's really helpful if we can start trying to find the words for the children to be able to use so that they can explain, perhaps in a classroom, as to why they can't do something. And they might need some concrete reminders, visual reminders, such as you need to go to the toilet every time there's a break, or every time 2 hours, or you need to eat at these particular times if they don't have that sensation of being hungry. Just an example of some of the things for eating. Taking eating just on its own, that involves your smell, your taste, texture, feeling hungry, feeling full. So all of that just in one bit of eating. It can impact on the feeling of pain or not feeling pain, actually. And all of that can impact on learning, even just one tiny little thing, such as a loose thread on a jumper, and that starts to itch. And that can take the child's whole information, whole concentration, and therefore not able to learn. Now, some people think, oh, the child's been rude, they're ignoring me, they're not looking at me. So really, it's important to advocate for your child with that kind of area. Some things that have been researched that are found to be really helpful that you can teach your child, or that you can do for your child, is things like tapping, deep massage, deep breathing, visualizing deep breathing like box breathing, and mindfulness. Those are just a few areas, but as I say, sensory processing is a huge area just on its own. So it's worth spending some time looking into this area. So I will just sort of summarize some of the strategies in saying communicate, short and simple, use immediate social rewards and positivity, nurture your child's strength if you possibly can, pick your battles and be realistic with this, parent by functional age and not the actual physical age. Michelle's already shown us sometimes how the age can actually differ with various activities. Keep a diary of what's working and what isn't working in triggers. Rehearse social interactions using role play, and do this again and again and again. Remember to take time and look after yourself. And in doing this, it's really important to build a network of support with family, friends, or parent carers themselves. Talking about services and support in East Sussex, what we have here is for educational support. So where you're having a bit of a tricky time, you're not quite sure what advice or support your child should be getting in school, the Amaze Sandias advice line is very useful. We also have navigation of pathways and list of different workshops that's been run through the Amaze ND Family Support. We have parent groups and befriending service, family hubs, which are across different areas in East Sussex. And we've got the FASD support group, which we're really excited about, that we will advertise that on social media and through Amaze and through the parent carer forum. So look out for that. The parent voice, this is so important. You know, one voice doesn't really hold much weight, but when you get to nearly 1,000 voices, then we start to hold a bit of weight. And East Sussex Parent Carer Forum has been extremely supportive for me. And then benefits, it's really hard to hold down a full-time job as a parent carer. And so Amaze benefit support has been really useful as well to show you what you can apply for and how you can apply for it. So similar services for Brighton and Hove. Again, you've got your Amaze and DS, your family support, your parent groups, family hubs. Your parent voice in Brighton and Hove is Parent Carers Council PAC, offering the same support that the Sussex Parent Carer Forum would do. And then again, your benefits support. And then your services and support in West Sussex. So for education, you've got your West Sussex Sendia support. Again, you've got your neurodevelopmental pathway navigation service. For parent care support, you've got reaching families, umbrella support groups, and befriending service. Again, you've got your family hubs. and it's the West Sussex Parent Carer Forum for Parent Voice, and the benefits support will be your Reaching Families benefit service. So NHS services and support. So every child, as we've already said, is different. And for some of your children, you may or may not need other therapists. And it's really important to speak to the professional that has diagnosed your child or has been working with your child to see what other therapists might be important. And what we've got here, just as examples, is, and Michelle has already mentioned it, so occupational therapists. So occupational therapists will support your children, your young person, developing their fine and gross motor skills, cognitive skills, social skills, independent living skills, and they can also provide strategies that can help with the sensory processing issues that we've just talked about. So speech and language therapists, they can support children with speech development, receptive and expressive language development, and visual resources for those children that have got non-verbal or developing language. And then physiotherapists, they can provide treatment designed to enable children to achieve their own level of functional motor skills, such as sitting, standing, jumping, walking, running. Toys, games, and specialist equipment will be used to encourage the development of child's motor skills in conjunction with specific handling skills. So the physiotherapy program should become part of the child's daily activities during the day as part of their day-to-day care and play. So you might want to pause the video at this point. These are some really useful websites for you to be able to look into. So the National Organisation for FASD, FASD Network UK, they all have loads and loads of information on there. So it's really worth spending some time on them. Michelle is now going to talk about the local assessment pathway in Brighton and Hove.
So I work in Brighton, so I'm going to talk a little bit about how we assess FASD in Brighton. Our Child Development Centre accepts referrals by GPs, health visitors, or school SENCOs. If we have a referral by the GP, we will usually write to the school to request further information about the child's functioning within school. The referrals are triaged, and if the referral meets our Child Development Centre referral criteria of significant developmental delay or learning difficulties or significant social communication difficulties, we will accept the referral. The child will then be seen in clinic with their parent or carer, and at that appointment we would take a full history and examine the child, and we will assess the facial features as well at that appointment. Following the appointment, we will then collate further information about the central nervous system impairments. So we may send out further screening questionnaires. We may make referrals to other professionals. For example, if there's concern about fine motor skills, we'd make a referral to occupational therapy. If there's concerns about language skills, we might make a referral to speech and language therapy. We also have a psychologist who works with us for a couple of days a week. And so if there are concerns about things like memory or cognitive skills, we may make a referral to our psychologist. We may also decide that the child should have some genetic testing, which we'll arrange. And we may decide that we need further information about alcohol history. So we sometimes go back and we'll ask parents if they can, for example, in the example of adopted child, if they can find that early information about the alcohol consumption, because as we've seen in the previous slides, that's really important for making the diagnosis. Now, this bit can take quite a long time, in many months and even up to a year or so for this, in order for further referrals to be made, for assessments to be taken place, for those referrals to come back to the paediatrician to then be able to collate all of the information and look at whether or not that meets the criteria for the sign guidance for a diagnosis of FASD. Once all that has come back, the child will be discussed in our FASD peer review meetings. That's a meeting with other paediatricians doing this work, and we look at the information that we have and look at the sign guidance together to see whether we think that the criteria has been met. We then feed back to the parent or carer to the child and young person as appropriate, usually not at the first feedback, but maybe a bit later on if that's the child's the parent's wishes. And then we would send a report to the parent and to the school as well, so that the child can be supported in school. At this point, we would signpost to websites and organisations that can be helpful. Unfortunately, we don't have a post-diagnosis package for FASD as we do with autism in our child development centre. So our pathway has been in place since 2016. So I think we were probably one of the earlier child development centres to try and look at FASD. And we had an awareness raising online event in May 2022, which was very well attended. And this was attended by some parent carers, was attended by social workers, was attended by some SENCOs from schools, and we had very good feedback on that. So hopefully that helped to increase the awareness of FASD within Brighton and Hove. So we didn't receive any additional resource or time allocation for FASD assessment, which means that, as I said before, it's a bit of a lengthy process to collate all of the information that we need. We often have to rely on assessments that have already been carried out. So, for example, some of the children that we see have had some assessments, maybe as part of the Adoption Support Fund, and if they've had the sort of standardised assessments as part of those assessments, we would use that information to help us to see whether the child meets the criteria for FASD. We don't have the resources to be able to assess each domain laid out in the sign guidance for every child, unfortunately. And the children that we assess must meet our existing CDC referral criteria.
Thank you very much for watching, and a huge thank you to Dr. Bond for all her time, and to Amaze for everything that they have done to make this possible, and for everybody who contributed to the survey. So our thanks to you for that.